about demyelinating disorders, some high-yield concepts we need to know, the likes of multiple sclerosis, Guillain-Barré syndrome, and the likes. Okay, and we'll also go into some of into herniation syndromes and some of the neurocutaneous disorders. I'm just going to take the high-yield stuff so that we can try and round up neuro on time. Um, you do not need all the details in neurology. The only thing you need are the high yield details. This will save you a lot of stress. And I'll try my possible best to see how I can simplify that for you guys. So let's start off basically. So yesterday I was talking about the movement disorders, although I didn't finish one of it. I think the only one I didn't finish was um, uh, Wilson's disease. Yeah, so and hemibalismus. I talked about hemibalismus earlier on, and I described it as um, a kind of wailing, flinging motion of the extremities that occurs due to a damage of the subthalamic nuclei. So for the movement disorders, you need to know which is very much high yield. You need to know the exact nuclei or nucleus that is affected. Okay, so for the hemibalismus, it's actually an injury to the subthalamic nuclei in the basal ganglia. And then for the Wilson's disease, it's actually due to an abnormality in copper transport, the absorption, reabsorption, and then there's a large accumulation of copper in the body and
Yeah, no,
deposits in the basal ganglia. Can you hear me, guys? Can you hear me, guys?
yes, I can, but your screen is not there. Or you are still,
Okay, yeah.
yeah,
I'm trying to just yeah, I'm just trying to say
yeah.
something. I'm trying to round up yesterday's topic. I'm going to write for those conditions. Don't worry. I just want to round up this one so that I can start the other. These were the only two topics I didn't talk about yesterday. But Wilson disease, we'll talk more about it in GI. I just want to talk about the dementia aspect where it's actually affecting. Okay, so for the Wilson's disease, right? So yeah, so for the Wilson's disease, yeah. So for the Wilson's disease, basically, the part of the brain that is just affected is the lentiform nucleus, right? And this disease is known as
Hello,
hepatolentiform
Dr.
degeneration.
Ovis. Hello.
Can you hear me?
Hello,
Yeah,
Dr.
can you hear
Ovis.
me? Yeah, can you
Hello,
hear
I'm
me?
Dr. Ahmad. Dr. Ovis, can we just please wait for 2 minutes for the students to join? So students are
Okay.
joining, so then it's going to be really difficult for them. So let's start the session
All
after
right.
2 to 3 minutes. Okay? Okay?
Okay. Sure. Sure.
Thank you.
Excuse me, sir.
Yeah, hello. Welcome everyone. Let's just wait for 2 minutes for others to join and then we'll continue from where I stopped.
Sure, sir. So actually, I had this question. For whom is it? These sessions are for whom exactly?
Yeah, so sorry, I didn't get your question. Can you repeat it again?
These sessions are for whom exactly?
Can you type it? I'm struggling to hear you basically. I don't know if it's your network. I'm struggling to hear you. Can you type your questions on the chat box?
Yes, I understand. Actually, Dr. Ilya want to say that these sessions are for whom. So basically, we have a program called 120 Days Marathon. These are for the students who are taking their step one, right? So this is basically, these are the sessions for step one, USMLE step one. Okay.
Okay, sure. And how many sessions have been done till now?
Till now, we did a lot of sessions. We would say 6 to 7 systems. We started from cardiovascular, right? So if you know the detail, if you want to know more about the details, you can just contact me. You might already be there in the groups. Dr. Ahmed, just contact me and I'll just guide you about the sessions. Thank you.
Sure. Dr. Ahmed, I assume you are from South Asia. Excuse me, sir.
Are you talking to Dr. Ahmed?
Yes, sir.
Okay, okay. I don't know where he went to. I guess he's from Southeast Asia.
He is from South Asia, as far as I can think, because according to our curriculum, South Asian curriculum, step one falls under the first, second, and third years. So I'm a first year student. So should I be continuing the session? I had to ask this.
Okay, I think I should allow Dr. Ahmed to answer that question. I'm not really familiar with how the curriculum is over there. So I think you can just ask him your question basically. I don't know where he went to though, but he's supposed to be here. He would answer your question definitely.
Thank you so much.
Welcome.
Yes, Dr. Ohils, you can just start, please.
Okay. Yeah. Okay. But I think Dr. Elia asked the question. I don't know if you were there when she asked the question.
After the session, we'll just keep a question and answer sessions. You can just ask a question there. Time. So let's just start our session.
Okay. So please, can we mute our mics so that we can start? All right. So yesterday I was talking about the movement disorders as well as the neurodegenerative disorders associated with dementia, right? And then yesterday I didn't talk about two other topics that are very high yield that I want you guys to also know, which is the Wilson's disease. So basically, it actually has to do with an abnormality.
Everybody mute
Abnormality
their
with-
mic. Not hearing.
Hello, Dr. Dagana, can you mute your mic, please? All right, great. Yeah, yeah. So I was talking about Wilson's disease. I was talking about the two other topics the two other disease conditions I didn't talk about for the movement disorders, and that includes the Wilson's disease and the hemibalismus, right? And I discussed, I think, in one of our classes about hemibalismus, right? Hemibalismus, and I said it's a flinging kind of movement of the arms, right? Flinging kind of movements, right? They also have wing beating tremors. So basically, this is a kind of tremor that they put their hands together and they kind of like move their elbows. So it's a kind of tremor that you put your hands together and then you move your elbows, that kind of tremor, something like this basically, okay? So that's what you find in patients with Wilson disease. It's also known as hepatolentiform degeneration. Hepato. Lentiform degeneration. DG. So basically, it involves the liver and the brain. Yeah. So the patients present with features of dementia, of course, neurocognitive declines, and then the moving disorders, which is which is this wing beating tremor. That's what they have here in Wilson's disease, and then they have features of dementia. So that's what I just wanted to add to the topics as regards movement disorders. Is this just a quick summary of it? I don't want to really dwell here because that's not the main topic for today. Okay. So the main topic for today basically is demyelinating disorders, right? The main topic for today, the one we're going to handle today is demyelinating disorders and neurocutaneous disorders. So we're handling two topics today, okay? I'll try and make it as brief as possible and as simple as possible, right? So demyelinating disorders. and neurocutaneous disorders, right? Okay, so for the first demyelinating disorder we're going to talk about is multiple sclerosis, right? So multiple sclerosis basically is an autoimmune condition. So it means that the immune cells are acting against the body's function, basically. So they are attacking certain cells in the body, right? And the particular cells that they are attacking are known as oligodendrocytes. Oligodendrocytes, right? The function of oligodendrocytes. Oligodendrocytes. Can anyone tell me the functions of oligodendrocytes?
It myelinates the neurons of the central nervous system, especially the
Yeah, great.
brain.
So
As brain.
yes, yes, that's correct. So they myelinate the neurons of the central nervous system, including the brain, the spinal cord. So basically, it's mostly an upper motor neuron lesion from what from what we're understanding. Basically, since it myelinates neurons that are found in the brain and the spinal cord, so it's an upper motor neuron lesion. So basically, one of the presentations that this patient will have is that they will have spastic paralysis. That's the first one. Spastic paralysis, right? And then, of course, because they myelinate neurons that are, how will I put it now, that are more of an upper, that are more of the brain and the spinal cord. And you need to know that the retina, or the eye, basically, the eye is a direct extension of the central nervous system, right? The eye is a direct extension of the central nervous system. So the eye is a direct extension of the central nervous. So of course, um, the autoimmune antibodies will attack the eyes as well, and this will lead to optic neuritis. They usually attack the cranial nerve too. That's the optic nerve, and they usually have this what we call it. We call it a acute mononuclear vision loss. It's usually very painful, right? That's the presentation. But what you need to know basically is the pathophysiology. What happens? Autoimmune condition, a type 4 hypersensitivity reaction, where the autoimmune antibodies are produced against the oligodendrocytes that myelinate the CNS and the spinal cord. Usually more commoner in females. So basically, the question will be in such a way that they'll be describing a female, a lady basically, that has this condition, right? Usually in her 30s into her 40s, around that age range. And then it has a very weird presentation. It means that people who are exposed to hot baths tend to have exacerbations of the attacks. Okay, so basically it affects all parts of the central nervous system, which is the brain and the spinal cord. So these patients present with different kind of presentation. So they present with cerebellar dysfunction. They can have ataxia. They can have this dysatria. They can have neurogenic bladder and the likes. Okay, so these are all their presentations. The presentation is not really high yield. Really need to know for the exam is that optic neuritis is a very high yield symptom that you need to know. Optic neuritis, right? Most patients with um, multiple sclerosis usually come down with optic neuritis, and they tend to have this relapsing and remitting. So there are some times where they'll have a relapsing and remitting presentation, and that is the most commonest form actually. So there are times where the symptoms will kind of submerge, and then there are other times where they'll have an acute flare. So it comes and it goes basically. That's the most common form of it. Now, there are certain things that have been postulated to be strong risk factors for patients coming down with multiple sclerosis. The first one is that the person is usually female, so there's an increased risk in patients who are female. The second one is that there tends to be a lack of vitamin D. So it has been postulated that a lot of patients who come down with multiple sclerosis tend to lack vitamin D. And a lot of studies have shown that patients that also come down with multiple sclerosis tend to live very far from the equator, and then it kind of affects the white matter, to be exact. Okay. What do we need to know for the exam? Basically, these are the high yield things you need to know for the exams. the presentation, the high yield presentations that they usually have is the optic neuritis. That is very high yield. You must know that for the steps. Okay, and it differentiates it from a lot of other demyelinating disorders, as you would see when we're attending to the others. Another thing that you need to know basically is how do we diagnose multiple sclerosis, right? How do we diagnose multiple sclerosis? This is also very high yield for the exams, right? The first thing you need to know is that you have to do a CSF analysis. That's the first thing. And then you do an MRI, right? An MRI is the gold standard to diagnosing it. And when you do CSF analysis of a patient with multiple sclerosis, what you're going to see are called oligoclonal bands. This is very, very high yield, right? Oligoclonal bands, very, very high yield for you to know. You need to know this, right? And it's usually IgG, right? IgG. So there's a large amount of IgG oligoclonal bands in the CSF when you do a CSF tap, yeah? And then when you proceed to do an MRI, what you see is periventricular plaques. Periventricular plaques. So these are like, how will I put it? These are like inflammatory, degenerative products of the white matter. So basically, let me show you this. Let me show you the slide so that you can see this, right? So let me show you this slide so that you can see this, right? Okay. So basically, this is what you're going to see on the MRI scan of patient with multiple sclerosis. These whitish things you're seeing here are more like reactive gliosis, destructions of the white matter, and then you see it around the ventricles. When you see this in an exam, it is multiple sclerosis until proven otherwise. Okay, it's multiple sclerosis otherwise, especially in a female, right, with optic neuritis. Those three things, when you see them in an exam, it's multiple sclerosis until proven otherwise. Okay. Now, another thing you need to know is how do you treat patients with multiple sclerosis? The treatment is also very high yield. So there are things that you do to kind of like stop them from having an acute flare or relapsing, right? And then there are things that you give for symptomatic treatments, basically. So for patients who have relapse, tend to, they tend to have this, like I mentioned earlier, they tend to have this relapsing remitting course. For those kind of patients, you want to give them drugs that are kind of like immune modulators. And then there's a mnemonic I use to remember that anytime I'm stuck in the exams and I can't remember the drugs you give patients with multiple sclerosis to kind of like stop the relapsing phase and remitting phase, I call it NIG. People who come from Nigeria will know that this is like kind of like the shortened mnemonics for Nigeria. And so the first one is natalizumab, right? Natalizumab. The next one is interferons. And the last one is glatiramer. Right? So these are the drugs you give to stop the patient from having an acute from having a relapsing remitting course, basically. So to stop the number of relapses that the patients have, you give this drug, right? These are the drugs you give. You call it NIG, right? But if you want to treat a patient with an acute flare, so a patient with an acute flare, basically, so you give steroids, give IV steroids, right? Because it's marked inflammation, basically, steroids will be very, very useful for these patients, right? For acute flares. You give them steroids. I think the best one you give them is methylprednisolone. Yeah, so you give them high dose methylprednisolone, and then you help with the acute flares. And then for symptomatic treatment, the patient has spasticity, you give baclofen, you give GABA, GABA, and then they have neurogenic bladder, you do catheterization, you give antimuscarinic agents, and this will help with certain presentations that they have. Okay. Do we have any questions as regard multiple sclerosis? These are the high yield things you need to know, basically. I won't bother you with things that you don't need to know for the exams. Do you have any questions? Yeah, Dr. Surafel. Okay, so there are no questions. Let me go ahead then. Okay, so basically that's all we need to know about multiple sclerosis. Very straight to the point topic, what you just need to know for the exams. To get almost all your questions on multiple sclerosis, you just need to know these things that I've just explained. And then there are other conditions that we need to talk about, such as Guillain-Barré syndrome. I'm going to also talk about that because that is also high yield, comes out in the exam a lot. So Guillain-Barré syndrome is a form of what we call AIDP. Okay, it's the commonest form of AIDP. That's acute inflammatory demyelinating polyneuropathy. Acute inflammatory demyelinating polyneuropathy. And Guillain-Barré is one of those syndromes, right? It's one of those conditions. So what happens in Guillain-Barré syndrome basically? So it's the same thing. You're having an autoimmune reaction, or rather an autoimmune attack, to not just the central nervous system, right? You're having this to the sensory nerve and the peripheral nerve. So usually what happens here is that the patient has, let's say, an earlier infection, and the commonest organism that's implicated in this is Campylobacter jejuni. Campylobacter jejuni is the commonest organism that is implicated. So they usually tell you that the patient maybe perhaps had a bloody diarrhea, or they might tell you that the patient ate maybe undercooked chicken grills or something like that, and then the patient started having bloody stools, and then let's say two and extreme weakness, they're ascending upward, right? So basically, this description I just gave you right now is a patient that has Guillain-Barré syndrome. So what happens basically is that when the patient first encounters this bacteria, right, the body tries to defend against it, and then the body develops antibodies against this particular bacteria or some product of the bacteria, right? And then some of the product of these bacteria are kind of like similar to some of the proteins that we have on, on the peripheral nerves, basically. And then what happens basically is that those antibodies that have been produced after this infection go on to attack those peripheral nerves and sensory nerves, basically. So when that happens, it is known as molecular mimicry. So that's called molecular, right? Mimicry. Mimicry means to copy something, right? So the proteins that are located on this bacteria basically have similar configuration with those that are located in the peripheral nerves, basically. And so when an antibody is produced long after the infections, those antibodies will be able to recognize those proteins that have similar configuration with that bacterial protein, and then start attacking them. And those proteins are usually located in peripheral nerves, basically. And then the patient presents with this lower muscle weakness. The patient also presents with deep tendon reflexes, reduced deep tendon reflexes. This is in contrast to what we have in multiple sclerosis. So one of the ways you can differentiate between multiple sclerosis and Guillain-Barré syndrome is that for patients who have they tend to have more of upper motor neuron reflexes. That means the patient might come down with hyperreflexia or normal reflexes. This is in contrast to patients who have Guillain-Barré syndrome that they come down with reduced deep tendon reflexes or literally absent reflexes. Yeah. And then another thing we need to know basically about Guillain-Barré, which is very, very high yield for the exam, is that one of the commonest causes of death in these patients, right? The commonest cause of death in this patient, which is something that you must know for the exam because it comes out like crazy in the exam, is that these patients tend to have respiratory failure. That's like the commonest cause of them dying, basically. So they tend to have respiratory failure. Yeah, so respiratory failure is the commonest cause of death in patients with Guillain-Barré syndrome. So death, right? And this is also very high yield for you to know for the exams. And how do we diagnose this disease condition? So basically, we can diagnose this disease condition through doing a CSF first. So CSF is very important in diagnosing this condition. And then what do you see on CSF is something known as So albumocytological dissociation, right? So basically what you have here is that you have an increase in protein and then the cells are just basically normal, right? So what it simply means is that basically it's not really an inflammatory reaction. So it's just basically an autoimmune reaction. And you see that in the patient's CSF. And that's very high for you guys to know. And that's what I'm trying to show here. Yeah, you can see that there's increased CSF protein, but the cells are actually normal. Okay. And then how do you treat this acutely? You do what we call a plasma exchange therapy. So basically you're trying to remove those antibodies that are kind of like sensitized or to the proteins that are located that are, to the proteins that are located in the peripheral nerve. So you want to remove those antibodies so they don't go on and attack those cells. Or another way you can do that is you can give an IV immunoglobulin that goes in, binds to those antibodies that have already been produced to attack the peripheral nerves, right? And eliminate them basically. So the two ways of treating it basically is that you're trying to do plasma exchange. So it's called plasmapheresis, right? So you go in, you try and remove the antibodies that have been produced against the organism, the Campylobacter jejuni. Those antibodies, you try and remove them so that they don't go on to harm, those peripheral nerves that would cause the symptoms of Guillain-Barré syndrome. So basically, that's how you treat them. That is what you need to know for the exam. You don't need to know so much for for Guillain-Barré syndrome, apart from what I'm just telling you right now. This is what comes out a lot in the exams. This is what is most commonly tested and what you need to know, basically. Okay. Do we have any questions? Can I go forward? Do you have any questions, guys? Okay. The other
Can
viruses
you
that
tell,
can also, yeah.
can you tell about cytological dissociation?
Okay, yeah. So what basically happens in this cytological dissociation basically is that because it's not an inflammatory reaction, yeah. So the white blood cells and basically all the immune cells are basically but of course there's destruction of what do you call it, of of proteins, basically of neuronal proteins, of peripheral nerve proteins, and then this accumulates in the CSF, and then there's an increased CSF protein level, and then the cells are basically normal because it's not an inflammatory reaction, basically. So the cells go up, but the protein goes up, but the cells remain normal, basically, because it's not an inflammatory reaction. So that phenomenon is known as albuminocytological dissociation. So there's a dissociation. Ideally, basically, in an inflammatory reaction that's caused by an organism, you would expect that if the protein goes up, so does the cell count. But because it's not an inflammatory reaction, the cells remain almost normal, and then the protein level goes up because it's destruction of peripheral nerve proteins and sensory nerve proteins, and then you see that in the CSF. So that's a way of like diagnosing it. I don't know if that kind of like answers your question. Okay. So let's go further. So things here. Another demyelinating condition is also very high for the exam that I need to emphasize at this point is CMT disease. So this is known as Marius tooth disease, right? Carries Marius tooth disease. So what do you need to know for this basically is an exam? You just need to know 4 things about this basically, right? The first thing you need to know is that it's autosomal dominant. So it's an AED disorder. It's an AED disorder. So it's an hereditary form of kind of like a hereditary form of motor and sensory dysfunction, basically, right? So it's genetic, and there's a particular gene that's implicated in this disease condition, and we call it CMYC. CMT1A, right? CMT1A. That's the gene that is implicated, right, in this disease condition. This normally they ask this in UWorld, but I don't think it's really high yield for these exams. They ask it in UWorld and MBMEs. But all you need to know basically is an autosomal dominant disease condition, and it's usually associated with duplication of this gene, PMP22. You don't really need to know these genes. They're just maybe for just reference sakes, but they're not really high yield for the exams. So that's the first thing you need to know. The first thing you need to know that it affects both sensory and motor nerves, and it's hereditary, right? That's the first thing you need to know. The second thing you need to know about is that it doesn't involve any organ, So it doesn't affect the heart, it doesn't affect the pancreas, it doesn't affect the brain, it doesn't affect any organ in the body. So there are no organ involvements, right? And this is how you differentiate it from Friedreich's ataxia, because it's almost similar to Friedreich's ataxia. But the difference between this disease condition and Friedreich's ataxia is that there are no organ involvement in CMT disease. But in contrast to Friedreich's ataxia, you have organ involvement. So the pancreas is involved, the heart is involved. But in CMT disease, those organs are not involved. That's how you differentiate it from Friedreich's ataxia, basically, right? And the next thing we need to know is that what this mutation does, is that it causes an abnormal production of defective proteins that are needed to synthesize neuronal proteins. So there's a defective production of neuronal proteins. That's what this abnormality in this gene causes, basically. But what you need to know for the exam, basically, the high yield stuff you need to know for the exam is these things I'm telling you. And last but not the least, they usually present with foot disorders. So they present with hammer toes, right?
Sorry,
And
sorry, I didn't get
yeah,
the mutation. You said there is abnormal production of what? I
yeah.
missed
So
it.
what happens here basically is that there's abnormal production of proteins, right? And they're more like structural proteins. They're like structural proteins that neurons need to, carry out their functions, basically, both motor and sensory neurons. So these proteins that is produced by this CMT1A gene, right? They're needed for like normal functioning of structural proteins for nerves, right? For peripheral nerves and sensory nerves, and also motor nerves. But what happens here is that when there is a defective production of that protein, which is as a result of the mutation in that CMT1A gene, these patients come down with sensory and they come down with sensory symptoms, as well as they come down with motor symptoms, right? So that they have muscle weakness, and then they have loss of loss of sensation, basically, right? So the pathophysiology is that there is a genetic mutation, and the mutation affects the CMT1A gene. And then what does that lead to, basically? That leads to abnormal production of structural proteins. So there's a production of proteins, but it's abnormal in a way. And these abnormal proteins can allow the neurons to have a normal structure, right? And if they don't have a normal structure, it means that they can't function properly, basically. So um, the patient presents with both motor and sensory symptoms, right? Patient has weakness of the extremities. Patient has other abnormalities such as hammer toes and pes cavus. And then the patient also has loss of sensation and deep tendon reflex, because, like I said, this is more of a lower motor neuron lesion, not an upper motor neuron lesion, right? So I don't know if that's clear. Did we get that? So the gene, let me just repeat this again.
Yes, sir, it's clear.
Yeah, so the genes that are affected, PMP22 and CMC1A gene. right? Those are the two genes that are affected here, right? Now, I said that you differentiate these from Friedreich ataxia because there are no organ involvement. This is very, very important. No organs are involved. So it's just only motor and sensory. There are no organs involved here for CMT disease as against Friedreich ataxia. Please, you need to note this, right? If you see a question that has patients with hamartos, pes cavus, and then they're telling you that the pancreas is affected. Okay, the patient has maybe diabetes mellitus or is having hypertrophy, cardiomyopathy, or something relating to any organs. It is more of Friedreich's ataxia as against CMT disease. Okay, that's how you differentiate both of them. Do we have any questions about this so that we can move on? Are there any questions? Okay, so no questions. Let's go on. Yeah. And then the next thing we're going to talk about now, basically, we're going to move from this now to the neurocutaneous disorders. But before we move to the neurocutaneous disorders, there's something I wanted to discuss with you guys in the last class. I had to do with enunciation, but let me just wait till I get there, though. Yeah, so we're going to talk about neurocutaneous disorders quickly, right? The 5 of them that you must know for the exam, and they are all high yield. They are commonly tested in the exams. They are commonly tested in the exam. I can't overemphasize this, right? All of them are commonly tested in the exams. You need to know all of them, and I'm going to help you with a way for you to know, a simple way, a simple hack for you guys to know each and every one of them, right? So the neurocutaneous disease, we're going to start with the first one. The first one is Sturge-Weber. So Sturge-Weber, right? What is the genetic basis of this disease condition? So there is something known as there's a gene known as there's a gene known as GNAC, right? GNAC. Yeah. And this gene has a particular kind of function. So early in the embryological development of the brain, this gene helps to kind of tell the blood vessels, kind of differentiates the blood vessels in the brain into kind of veins, arteries, and capillaries. So this gene is responsible for that in development of the brain. So what happens basically in Sturge-Weber is that there's a somatic mono all these kind of biochemistry terms, monozeism. There's a somatic monozeism of this gene. So monozeism means that you're having 2 different forms of a particular gene, and then it kind of affects, it's only found in somatic cells, right? Somatic cells, basically. So when I get to biochemistry, I'm going to explain a lot about this. I'm going to talk more about this, basically. But for now, what I want you guys to know is that the gene that is implicated is the gene that you just need to know. The condition that happens, basically, we'll deal a lot of that in biochemistry. But what you just need to know is that there are 2 forms of these genes, and then one of them has an abnormality, basically. And you need both of them to function, right? You need both of these genes to function. And what this gene does is that it helps a signaling process within the brain to kind of differentiate blood vessels into veins, capillaries, and arteries. So when there's an abnormality of this, the blood vessels in the brain are not able to differentiate into any of these, right? You can't differentiate into any of this. So basically, you kind of have abnormal blood vessels in the brain, something like that, yeah. And so these patients tend to present, first of all, basically, all neurocutaneous disorders present with 3 symptoms. There are 3 symptoms they present, or 3 organs that are affected. So the brain is affected, right? The skin is affected, and then there are other organs that are affected. So we're going to answer their we're going to explain their manifestations in this manner. We're going to talk about the brain manifestation, the skin manifestation, and then other manifestations, okay? So what happens basically is that blood vessels are not being well formed in the CNS because there's a mutation in this GNAC gene, GNAC1, actually. So what happens in the brain is that These patients tend to come down with a very kind of weird kind of disease condition, yeah. And so they present basically with, the first thing they present with is what we call ipsilateral. So they present with ipsilateral leptomeningeal hemangioma, right? Leptomeningeal angioma. The word angioma referring to blood vessels that are malformed, especially in the arachnoid and pia mater, and it's usually ipsilateral. That's basically like, it's self-explanatory. So an ipsilateral abnormal blood formation within the arachnoid mater leads to this condition, right? So another feature that they have, another neurological feature that they have basically is intellectual disability. So usually in the question, they won't really put that, but what they do in the question is that they put a picture. So let me show you guys this picture. Very, very high yield for the exams. This is the picture they usually put up, right? So you can see this, right? This is known as a port wine stain. What you're seeing here, this picture is usually very high yield for Sturge-Weber syndrome, basically. And so these patients usually present with, I told you guys that there is abnormal blood formation, abnormal blood vessels formation. So you can see everything about the pathophysiology is relating to blood vessels, right? So there's another blood vessel formation, and it's usually ipsilateral, usually unilateral, right? And it usually follows the distribution of the trigeminal nerve, right? So another name for this thing is known as encephalo. Yeah, you see here already, encephalo trigeminal angiomatosis, meaning that it follows the distribution of the trigeminal nerve. So they have that thing called port wine stain, right? Port wine stain. So the most important presentation you must know for Sturge-Weber basically is the port wine stain. That is the most high yield thing you need to know. So that picture I showed you earlier on, you need to know that. And then these patients are also at risk of a very weird condition as well, which I classify as others, basically. So these patients tend to have what we call an hemangioma, and usually episcleral. That means it's in the eye. So anytime you think of Sturge-Weber, think of the eye. That's the first thing I want you guys to think about: the eye and the brain. So they have this kind of like abnormal blood vessels just above the sclera that is very fragile and kind of like gets ruptured. And this particular thing here can lead to an increase in the intraocular pressure. So in the exam, they might just ask you, okay, this patient has Sturge-Weber syndrome. What other things or what other features do you think this patient can have in the next 5 years? So one thing that these patients are at risk of having in the next 5 years or 10 years is glaucoma. So they are at risk of having early onset glaucoma, right? Early onset glaucoma. So the three things you need to know basically is the pathophysiological mechanism, the genes that are implicated, what you see, what's the high yield feature you need to know about Sturge-Weber. They have port wine stain that follows the distribution of the trigeminal nerve, and then they're at risk of having glaucoma, right? These things are very high yield for you to know for the exams. So after Sturge-Weber, do you have any questions as regards Sturge-Weber? Is there any question we have regarding Sturge-Weber that I can clarify? Any confusions, Sturge-Weber?
What are the organ manifestations? Other organ manifestation that we can see in them.
Yeah, so the other manifestation of Sturge-Weber is the last thing I wrote, that it affects the eye. So the others means any organ apart from the brain and the skin. Okay, so the other manifestation is known as episcleral hemangioma, which leads to an increase in intraocular pressure because these blood vessels, they rupture, they increase the intraocular pressure, and then this patient tends to have early onset glaucoma. So that's the other features that they have. Dr. AZ, you put up your hand. Do you have a question you wanted to ask? Dr. Raina, I don't know if I answered your question. Okay, so let me move on. So is there a question? Okay, one could you can you ask your question?
Because you talked about the possibility of them having a seizure. Do you have any particular type of anti-seizure drug that may be used or that is being used?
For patients with Sturge Weber.
Oh yeah, you know, we said they could have seizure epilepsy.
Yeah, I think basically there's not really particular anti-epileptic drugs that you can give them that is kind of high yield. I don't know of anyone. But I think carbamazepine is okay. It's a good drug. I think it's basically good for epilepsy. So I think that might be okay. I don't really know if there's any particular one that's high yield for the exam that you should know. I don't think of any. Yeah. I don't know if that answers your
Any
question.
gender preference? Any
Gender
gender
preference? No, not that I know of. Not that I know of.
Thank you.
None that I know of. Or do you know of any gender preference? Of course, we learn every day.
No, not at all, because you know sometimes when you see some questions and they say a female, okay, you start having an idea, okay, this is what it could be and all.
Yeah.
Like when you see migraine, you start thinking, okay, it's a female, this, that, and hair, stuff like that. Help you narrow down your differentials.
Yeah. So that's a good question. But for the neurocutaneous disorders, I don't really think there's a gender preference. But what I can say is that for the autosomal dominant conditions, you should look out for more of male children than females. For the autosomal dominant, like the neurofibromatosis type 1 and type 2, those are tend to be autosomal dominant. So you should look more towards the male, or you should look for a history of, kind of like a male grandfather, father kind of, kind of linkage, basically. That's what I can tell you about that. I don't know if that helps. Yeah. So let's go to the next one. The next one we're going to talk about is tuberous sclerosis. I'll try and do justice to this quickly so that you guys can know this. Tuberous sclerosis. So as a recap for Sturge Weber, the most important things we have learned, first of all, we need to know is that the neurocutaneous disorders affect the brain, the skin, and other organs, right? So for the Sturge Weber syndrome, right, there is actually a somatic mutation, basically, in a gene known as the GNAC gene. And the GNAC gene is what helps to differentiate blood vessels in the brain into arteries, veins, and capillaries. So basically, when there's a mutation in that gene, that process doesn't happen. And so there's an entanglement and a formation of kind of like weak blood vessels, hence that are very prone to rupture. And then these patients, in terms of brain manifestation, they tend to have ipsilateral lepto meningeal angioma, and then they also tend to have intellectual disability. And then for the skin manifestation, they have the Portwine stain that follows the trigeminal nerve, right? And they can ask you in the exam, these patients are at risk of what? Just simple glaucoma, early onset glaucoma, because of the episcleral hemangioma. That episcleral epiangioma fulfills the criteria of others, right? And you must know that for the exam. And then for the tuberous sclerosis, TSO, I want you guys to remember this word. For the tuberous sclerosis, right? Before we start tuberous sclerosis, I want you guys to remember this word, TSA. TSA. Very important word that you need to know, TSA. Right? Because why? All the symptoms, like 80% of the symptoms of patients with tuberous sclerosis, all start with an A. All start with A. When I start explaining it, you guys will understand, right? You guys will understand. It also stands for mnemonics. I'm going to tell you guys this TSA. But let's just keep that aside, basically. So what happens in tuberous sclerosis is that there's a mutation in a tumor suppressor gene. There are two of them. So anytime you think of tuberous sclerosis, I want you guys, two things to come to your mind, right? Just write on your paper, TSA. And the next thing I want you guys to know, for you to remember the chromosomes that are affected and what are the names of the genes that are affected. So basically, I want you to write 1 and 2, right? And then draw a straight line to 3. Draw a straight line to 2, right? 1 plus 1 here is 1 plus 2 gives you 3, right? These 2 that you added, you just added up here. I'm sorry, there's a reason why I'm doing this, so that you guys can understand. So right, this is equals to 4, right? And this is 4 raised to the power of 2, right? Now 3 raised to the power of 2 is 9, right? 4 raised to the power of 2 is 16. So it means that for the tuberous sclerosis 1, the chromosome that it's located on, TS1, the TS1 gene, the TC1 gene, is located in chromosome 9. And this is known as harmatin. They like to play with these things a lot in the MCQs. They play with it a lot. So I'm trying to help you guys with a way to kind of like remember so that you don't get stuck in the exam. And then you remember tuberin for right. So you have 2 plus 2 equals to 4. 4 raised to the power of 2 is 16. So TS2 is located, TSC2 is located on chromosome 16, while TSC1 is located on chromosome 9. So these are the 2 tumor suppressor genes that are affected in tuberous sclerosis. You need to know this because they twist it a lot. They can play with it in MCQs, and it can be a bit confusing for students. So I kind of like cooked up a way to kind of like remember it. So you just write TS1 and then you write TS2, and then you add 2 to the 1, it gives you 3, and then you square that 3, it gives you 9. You do the same thing for 2, it gives you 4, you square it and it gives you 16. So this tells you where the chromosome that each of the genes is located on, right? So this is like a hack to kind of like remember so that you don't get confused in the exam, right? And then the next thing you need to know about this is that what are the presentation? You know, I told you all neurocutaneous disease conditions have a brain, a skin, and others, right? And then for the brain, these patients tend to have a very weird kind of disease condition that I want you guys to know. Yeah, these patients tend to have what we call an astrocytoma. So let's start with the A. So for the A here, for the brain, you have astrocytoma, giant cell astrocytoma. So this A is what you have here, right? For the skin, we have another A, right? And this A, we call it ash leaf spots. Right? Ash leaf spots. Now, this S that is here, you can put it, right? This S stands for Chagrin's patch. I will show you guys all these images so that you can have an idea of what they look like, right? Now, this T stands for the tuberous sclerosis. So that's how I remember it. I remember tuberous sclerosis has Chagrin patch, has ash leaf spots, and has astrocytoma, basically, okay? Another thing that you need to know about this disease condition is that it affects the heart and the kidneys, right? The heart and the kidneys. It is the only neurocutaneous disorder that affects the heart. So when you see an MCQ question and you see the patient has a heart condition, right? You need to know that tuberous sclerosis is your answer. These two, why does it affect the kidneys and the heart? A way to remember it is that the kidney and the heart has tubes, right? Tubes, from the word tuber, it has tubes. So another way to remember the others for tuberous sclerosis is to think of tubes. Which organs in the body has tubes? And the two of them that has tubes basically is the kidneys and the heart, right? So patients with tuberous sclerosis tend to have renal angiomyolipoma, right? And then with the heart, they tend to have what we call a cardiac rhabdomyoma, right? Those are the two orders that they have. I'll go over it again. Anytime you think of the orders for tuberous sclerosis, what I want you guys to remember is the word tubes, 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 right? Tubes, the kidneys, the heart. So it affects those two organs. What are the presentations for those two organs? We have the cardiac rhabdomyoma, and then we have the renal angiomyolipoma, basically. So that's what they have. So you need to know that as the two other associations of tuberous sclerosis, right? I don't know if this makes sense. Is it difficult, or are my mnemonics a bit complex? Do you guys understand the mnemonics at all? Do you understand the logic behind these things that I'm saying? Okay. So do you guys understand it? Can someone say something so that I can know that you guys are following? Yeah, okay, so great. So
Yes, doctor.
Sir, yes, sir.
yeah. Okay, so great. Yeah, so I want you guys to remember anytime you see tuberous sclerosis, just remember TSA, right? Tubes that are TSA, tubes or TSA tubes. Let me just make it like that, TSA tubes. And then when you think of tubes, just think of the two organs. We have the heart, we have the kidneys, right? Those constitute your orders. That's what you put as your orders, the heart and the kidneys. Those constitute your orders. And then you remember the TSA, right? The TSAs. Those are like, gives you like, they help you to remember, okay, what conditions are involved in here and here and here, kind of like that. And then you go to the brain, you go to the skin. What do I have in the brain? These patients tend to have astrocytoma, giant cells astrocytomas, as what you have in the brain, right? That's one of the A in the TSA. And then when you come to the skin, they also have an A, basically. So I like to refer to tuberous sclerosis as a disease that has tubes and has a lot of A's in it, a lot of A's. So anytime you are confused in the exam, you're like, oh, which of them has an A in it? Basically, okay. So tuberous sclerosis. I'm trying to like make it easy for you guys to remember. I'm trying to like link the stuff so that it's kind of easy for you guys to understand, right? So let's move on. Then the chromosomes, for you to remember, just write TS1, TS2. You add a 2 to the 1, it gives you 3. You add a 2 to the 2, it gives you 4. Then you raise it to the power of 2 for each of them. You get 9, you get 16. So for the TS1, it means that it's located on chromosome what? Chromosome 9. And then for TS2, it's located on chromosome 16. These are where you can kind of like remember this stuff. I don't know if it makes sense, guys. I don't know if it makes sense, guys. Probably makes sense to me. I don't know if it makes sense to you guys. Okay, yeah, great. So let's go on. So that's all about tuberous sclerosis, yeah. Very easy in the exam. You see it's very, very easy. So let me show you guys how it presents basically. Let me show you guys how it presents basically so that you can have this. So let me show you guys. Okay, you have a picture here. Yeah, let me show you guys the picture. Yeah, so this thing you're seeing here, this here is the what do you call it? Ipsilateral leptomeningeal angioma that you're seeing in the brain. So they're like abnormal and they have calcifications. Yeah. Another thing you need to know about Sturge-Weber is that they have calcifications, right? So when you see this whitish thing here, it's more like calcifications. So for this is actually the Sjagren's patch. It's like the Sjagren patch. This is how it looks like. Yeah, this is how it looks like basically. So when we get to the other ones, I'll explain them, but that's basically how it looks like. I don't have a picture of the Ashleaf spot. When we're doing our slide review, I would show you guys all these pictures. I'll show you guys all these pictures, so don't worry about that. Right? And you need to know that these are autosomal dominant conditions. Autosomal dominant conditions. So you should know that because they put it a lot in the questions, right? So you need to know that it's autosomal dominant. So of course there'll be a kind of a history with a grandfather, father, kind of thing like that. So you should remember that. Okay. So the next one we're going to go to is neurofibromatosis 1 and 2, right? We're going to go to both of them, neurofibromatosis 1 and 2, right? And then we have neurofibromatosis 1 and 2. All right, so we'll start with the 1. So the first thing you need to know is that if you count the total letter, the spelling of neurofibromatosis, especially for one. There are 17 letters, right? Because there are 17 letters, it means it's located in chromosome 17. That's the first thing you need to know. The second thing you need to know is that there's a mutation in this gene here, right? There's a mutation in this gene here, right? And the mutation basically in this tumor, it's a tumor suppressor gene. Another name for it is neurofibromine. They like to play with these things in MCQ. So these things I'm writing are very high yield. Fibromine. They like to play with this in the exams. So you need to know these things I'm writing, guys. You need to know it. I'm not just writing it for fun. I'm writing it out because it's high yield, right? It's a tumor suppressor gene, comes out a lot in the exam. You need to know it's neurofibromine. I'm still going to give you guys a very crazy way to a lot more easy. And what you need to know, the mnemonics I've generated for this is MNOP17. Right? So just remember the letters from L to, so another way to remember it is LP, right? LP17. So the letters in between L to P is what, you know, LP17, basically lumbar puncture 17, like something like that. I don't know if you guys understand the logic behind that, really. So this tells you like the presentation these patients have, right? So L stands for what? The L stands for leach nodules, right? Leach nodules, right? Right. The M starts for what? Starts for a meningioma. Meningioma, right? A meningioma. The N stands for neurofibromines or neurofibroma, kind of like neurofibroma. So the N has two. Yeah, it has two basically. Right? The two is one, neurofibromines and neurofibroma. So neurofibromas are like kind of like skin manifestations, right? So the N stands for neurofibroma and neurofibromine. The neurofibromine stands for is the name of the tumor suppressor gene that is affected, while the neurofibroma is the presentation of like kind of like the skin presentation of neurofibromatosis 1. And then the O is an optic glioma, right? It's kind of like an optic glioma, yeah. So optic glioma, right? Right, and the P is a pheochromocytoma. Pheochromocytoma. So let me, I don't know if I can bring this down. So the P stands for pheochromocytoma. Pheochromo. So there are two neurocutaneous disorders that have pheochromocytoma. Chromocytoma. This is one of them, right? This is one of them. The other one is von Hippel-Lindau syndrome. So there are two that has this, but you should know this basically, okay? What do you need to know here again? You need to also know that this patient has Cafe-Liao spots. I don't know how to pronounce this, guys. Like, I'm not a French person. Do we have a French person in the class to kind of like tell us how to pronounce that?
Cafe ole. Cafe ole.
Yeah, cafe. Yeah, thank you, Dr. Raina. Cafe ole spots. So they tend to have that. They also tend to have cataracts. So just by the side. Yeah, Dr. Okodi, that's funny. Yeah, so they also tend to have cataract as well. So you should know that that's also very high yield. But how they test this in the exam basically is they tell you about the presentations, right? They tell you about the presentation. So the patient has, maybe the father had, let's say, the father had, or maybe the patient had neurofibromas, And then they might tell you, okay, what other investigations would you like to do for this patient? What are the other things would you want to do for this patient? Of course, the eyes are affected, so you want to do a fundoscopy for the patient. Also, you want to do an ultrasound scan for the patient to also check for the adrenals, or a CT scan to check the adrenals. So that's how they test it. So you need to know this, right? Of course, in UWorld, you see these things too, so you have to test it as well. So do you have any questions about neurofibroma 1? Do we have anyone? So the mnemonics is LMNOP, right? The mnemonics is LMNOP. It's very important that we should know that, right? Sorry, can you guys give me a minute, please? Let me just attend to something. Just give me a minute. Okay, so we can continue, right? We can continue right now. The next thing we're going to talk about, yeah, the M stands for meningioma, 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 meningioma. This is it right here, meningioma, right? Okay, so the next one we're going to talk about is the neurofibromatosis 2, right? We're going to talk about neurofibromatosis 2, right? All right, that's the first thing we're going to talk about, right? So what do we do for neurofibromatosis 2? There's a very easy way to remember the chromosome that's affected, right? I want you guys to remember this mnemonics. This mnemonics is called miss me. How many letters do we have here? 1, 2, 3, 4, 5. And you know, I told you that this one has 17, right? So in order to remember the chromosome that is affected, you just add that 17 for neurofibromatosis 1 plus these 5 letters, and it will give you what? To give you what? 22. So the chromosome abnormality for neurofibromatosis 2 is located on chromosome 22. Very easy way to remember it, guys. Very easy way to remember it. Very, very easy way to remember it. I don't know if you guys are following. Do you get that? Yeah. So you just add miss me. Miss me is like 5 letters, and then you add it to the 17 that you like kind of remembered, and then it gives you you add it to the 17, it gives you 22. So that's how you're able to remember the chromosome for neurofibromatosis 2. Another way you can remember it basically is that just remember 2, right? 2. Neurofibromatosis 2 affects the 2 eyes and the 2 ears. So when you have 2, it's like kind of like 22. Do you get what I'm trying to say? Like it affects 2 eyes and it affects the affects the 2 ears, right? For me, the easiest one is this miss me. Once I remember miss me, it's a lot more easier, right? A lot more easier. A lot more easier, right? A lot more easier. So what does the miss me stand for? Yeah, so the M stands for meningioma. The I stands for, I usually put this as ipsilateral, like kind of like ipsilateral. So kind of like the meningioma is ipsilateral. That's like the mnemonics, right? Ipsilateral meningioma. So the S is schwannoma.
Sorry. Is it ipsilateral meningioma? Okay.
Yeah, like I kind of like I just put the I there to mean ipsilateral basically. Yeah.
Okay.
So you know that, like, do you get me?
I think it's the multiple intracranial schwannomas, M for meningioma and E for ependymoma.
Okay, yeah, great. I think that's a better mnemonic itself. That's even
Yes,
so
because I
multiple
remember this
intracranial.
pneumonic disease. Yeah, multiple intracranial schwannomas and the
Yeah.
M for meningioma and E for ependymoma.
Okay, yeah, great. She even gave us a better mnemonic. So I was even going the other way. So it's multiple. So let me just put it like this. I think our own is way better. Thank you, Doc. Thank you, Doc. So multiple
Welcome, welcome.
intracranial. So let me just write this as IC intracranial schwannoma, and then we have the meningioma, and then we have the ependoma. Right. So remember the miss me for neurofibromatosis 2, it has 5 letters, and then you add it to 17, it gives you 22. That's the chromosome that is affected there. Yeah, I think that's that about that. Do you have any questions about this, guys? Any questions at this point? Any
The
questions?
first M. The first M.
You said what?
The first M. The first M
Okay, so
is
yeah, so the first M is multiple.
what?
Can you hear me? The first M is multiple.
Yeah.
The I is intracranial. The S is schwannoma. So they have multiple intracranial schwannoma. And then they have a meningioma, right? A meningioma for the second M. And then the E is an ependymoma, right? Right. So let's move on, right? The last one we're going to talk about is the von Hippel-Lindau syndrome. I think that's the last one, right? That's the last one, right? That's the last one. So that's the last one we're going to talk about, right? The last one we're going to talk about the neurocutaneous disorder. So the neurocutaneous disorder, the last one we're going to talk about is VHI. VHL, right? Von Hippel-Lindau syndrome. What do you need to know about it? Chromosome 3 is affected. It's also autosomal dominant. That's the first thing. Chromosome 3 is affected. Autosomal dominant. So there tends to be this gene called ubiquitin hypoxia inducible factor. It's a very long gene, kind of like HIA gene or something like that. HIA1 gene. It's not really high yield for the exam, but you just need to know it. It's in first stage. You can look it up, but I'm not really bother you guys about it. The most important thing you need to know about this is the presentation. The presentation basically is called HARP. This is a very common one. I took this from first aid because it's very easy. So the patient has hemangioblastoma. Right? Patient has hemangioblastoma. The patient has an angioma, or call it, some people say angiofibroma. But I just remember it as an angioma to remember it. And then we have bilateral renal cell carcinoma, right? And then we have pheochromocytoma. I won't say it's high yield, but you should know this. And how they usually ask this question, sometimes, is that they'll tell you that the patient has features of pheochromocytoma. They'll not ask which other investigation would you want to do for the patient. So you might need to do an MRI, you might need to do a renal ultrasound scan. So 2 investigations that you might need to do for the patient with von Hippel-Lindau syndrome, right? That's basically it about neurocutaneous disorders. I don't think there's any other thing that you need to know here. That's the high yield stuff. Do we have any questions before we move on? It's a lot of stuff, guys. Yeah, I know it's a lot of stuff to remember. But these things are commonly tested in the exams. In fact, I don't think there's a neuro question that you won't see one of them tested. It's that common, right? It's that common. Okay, so after that, the next thing I wanted to talk to you guys about, brain tumors will be the last, but I'm not going to go to brain tumors because that's a very like complex topic. If we have time, I might go into it today, but if not, then we might take it for the next class. I want us to finish neuro like kind of like today or tomorrow. I don't know how possible that is, guys. If it's possible for us to finish neuro today or tomorrow or Monday, so that we can go into other topics. Yeah. So let me just show you guys the picture. This is the Lynch nodules. This is very, very common. This is very, very common picture that comes out in the exam. This is also very common. These are the neurofibromas. You can see them here as well. Then this thing you're seeing here is the cafe au lait spot, or what, how did Dr. Raina call it? Yeah, so this is it as well, right? Yeah, this is the hemangioblastomas. You can see this red blood vessels. These are blood vessels, basically, right? Blood vessels you're seeing. And they are most commonly found in the retina. That's where you see this. That's where you see this, right? That's where you also see this as well. You see them in the retina. You can see them in the spine. This is the hemangioblastoma, right? Now, if we look closely at this hemangioblastoma, I wanted to show you guys something so that you can see it, right? I wanted to show you guys something so you can see it, because some people can easily confuse this thing with a meningioma, because a meningioma is very common with this, right? But the only difference between this and a meningioma is that a meningioma has what we call a dural tail, so a kind of like hyper dense extension of the tumor downward or upward. You see it basically in a meningioma, but you're not seeing it here. There's no extension. When we get to tumors, I'm going to explain that so that you guys can understand. Let's just leave that. So the next thing we're going to talk about is but at this point, do you guys have any questions before we go forward? You guys are not asking me questions. Did you understand the topic? I want to know. You guys should tell me so that I can know that I'm doing a good job. I'm not really just speaking so much.
Can you summarize VHL one more time, please?
Okay, VHL. Yeah. So I was talking about for VHL, right? What you just need to know, there are 3 letters, von Hippel-Lindau, meaning that it's located in chromosome 3. But that's the first point you need to know. It's an autosomal dominant condition, basically. You need to know that. The next thing you need to know is the gene implicated. So they call it hypoxia-inducible factor 1A. I can't really remember it's in first aid, basically. Let me just check it out. Yeah, so it ubiquitinates hypoxia-inducible factor 1A. Yeah, so I was correct, right? So that's the gene that's implicated, right? And then the mnemonics to remember the presentation. The presentation is called harp. Harp. Like harp. It's like an instrument. I don't know if you guys know a harp that they used to sing and all that. So the H stands for hemangioblastoma. The A stands for angiomatosis or angioma. And then the R stands for renal cell carcinoma. It's usually bilateral, right? And then you have pheochromocytoma. So usually how they bring the question out is that they might tell you the patient has features of pheochromocytoma, the patient is having pain, having pulsating headaches, having pallor. The P's of pheochromocytoma is there. And then they'll not ask you which other investigation would you want to do for this patient. Usually that's how the question comes. And then, of course, you need to know that you have to do a renal ultrasound scan. If there is no renal ultrasound scan in the question, you will need to do an MRI because these patients are at risk of having a blood vessel tumor known as hemangioblastoma. I don't know if that it's clear. Okay. So the last thing I want to talk about, a very simple topic I want to talk about before I go into brain tumors, very easy for you guys to remember, is herniation syndrome. This is how you do. Herniation syndrome, right? I'm going to talk about it because it's a very short topic that I can just wrap up in like 5 minutes, right? Yeah, so herniation syndrome, basically. So the first thing I'm going to do is I'm going to teach you guys how to draw the circle of Willis. Because it comes out in the exam, a way to name the arteries, because sometimes they can give you a picture of the exam, they can give you a picture of the circle of Willis and they will ask you to label it, they'll tell you what artery is here. So let me just draw this. It's a very funny diagram, right? So let's assume this to be the head of the individual. So it's like a guy. We're drawing a guy basically, right? And this guy has like an antenna. So we're kind of like drawing an alien, right? This is ACA. Let's start labeling it. These antennas are called the anterior cerebral arteries, right? I know why I'm linking this up to, and I know why I'm drawing this because I'm going to link it to herniation syndrome so you guys can understand, right? And then there's an artery that comes here that forms the eyes, right? Another one comes here, forms the eyes, right? And then you have the collar of the alien. He has like a bone collar or like a collar. The guy like wears a suit or something, so he has collars, right? And then these collars, let's label it as PCA. I want you guys to follow me with this. Let's try and draw the circle of Willis together, right? And then what you have here, this artery here is the middle cerebral artery. Yes. This is the part that supplies the brain, that is responsible for the face and the arms, while this one supplies the legs, right? Lower extremities, right? This one supplies the occipital cortex, right? Now let's draw this guy now has a long neck. So he has a long neck, right? He has a long neck and long body, right? And then this patient has like kind of like arms coming out. Firstly, has arms. It's like the arms. This is the neck. And then he has something that comes here, kind of like long cross sections here, right? And this is the superior cerebellar artery. Superior cerebellar supplies the cerebellum, superior cerebellar artery, right? These are like the arms of the alien. So this is like we're drawing an alien, right? And this artery that comes down here, like goes down here, is known as the basilar artery. So we have the basilar artery. And these vessels you are seeing here, these things here are called pontine vessels. Pontine vessels. So they're just shooting off the basilar artery, right? And then you have, when you get to this point, what you need to do, what I want you guys to do when you get to this point here, is to draw an inverted V, right? An inverted V. This is an inverted V, right? So you draw an inverted V here, right? Inverted V. So, like I said, inverted V. So V, we're talking of vertebral arteries. So these are the vertebral arteries, right? Of course, this guy has like a back. He has a lower back, right? Before this lower V, he has a lower back. So the patient usually, the way I remember this is that the patient has back ache, or ICA. So I kind of call this guy ICA, right? So he has a lower back, right? So I kind of call it like ICA, lower back ache. So the ache stands for ICA, ache. So he has a lower back. That's what the patient will have is ache, back ache. So that's how I remember it. ICA. So this is the anterior inferior cerebellar artery, right? And then when you come down here, the guy has like piggy toes, right? And the way I remember that piggy toes is like I kind of remember like piker. So he has legs or toes. So I call it pica toes or piker, pica toes, pica, like piker. Kind of way to like remember it. Yeah. There's a reason why I'm drawing this because of herniation syndrome. I'm getting somewhere. That's why I'm drawing this, right? And then the next thing you need to know, guys, the next thing you need to go after you have labeled all of this is that there are like two arteries that are coming out from like the patient's like, right? There are two arteries that are coming down here and here. So they are coming out of the ass of this guy, like the ass of this guy, the ass. So I call it ass, right? And this is the anterior spinal artery, right? Now, why am I drawing this? It's because of the herniation syndrome. I'm coming, I'll explain all this for you guys. So do you guys get this diagram? It's not really a beautiful diagram, but it's a way to kind of like remember this. I'm sorry, guys. Like, I'm sorry for using this diagram. That's the way I remember it, right? That's the way I remember it, guys. So that's like the cycle of Willis, so that it can be so clear for you guys. And then, what is important here for herniation syndrome basically is that, so in herniation syndrome, it's usually as a result of course, herniation, a displacement, right? So this is the person's head. Let me use first aid to kind of highlight this so that you guys can understand it. It's much better. So basically, this is the herniation I'm talking about, guys, right? This is the herniation I'm talking about. I'm talking here. So we have 4 types of herniations, right? Herniation syndrome. So we have the cingulate, which is C. I call it the sub-fall sign. And then I have the tonsillar or cerebellar, or we call it cerebellar herniation. And then we have the transtentorial herniation, You know, so I want you guys to just know this first. Let me clean this. But before I clean this, did you guys get this circle of Willis? Did you guys get it? Did you get how I drew it? So can you guys draw it on your own? Like, if you're at home, can you you can try and practice it and practice it and practice it, and then you get it, right? And then I want to clean it. That's why I'm asking, right? So I'm cleaning this up here, right? Cleaning this. Okay. Clearing this up because I want to try and explain something here, right? So this is the score, right? Let's call here the score, right? Let's call this the score. So this is the score of someone, right? Right, this is the score, right? This is the brain matter here. What you're seeing here is the brain matter, right? Now, there is a kind of like a dura tissue. So this is like a dura tissue here that covers the brain. So this is the brain here. This is the brain. This is the brain, right? And there's like a dura tissue that comes from this region here, that comes to this place, comes to the middle here, right? I'm sorry, guys. I just want to show you guys something. So this is the cerebellum. Cerebellum. That's cerebellum. Now, this dura tissue here that covers the cerebellum is known as the tentorium cerebelli. Tentorium cerebelli. From the word, it's like a tent. It's a tent over the cerebellum rather. A tent over the cerebellum, right? So what happens here? What happens here? Basically, let me just explain this for you guys, right? So there are 2 herniations that occur here, right? Under the what do you call it? The tentorial herniations. We can have a central tentorial herniation, and then we can have an uncal herniation, right? But anytime you see an herniation syndrome, you need to ask yourself 2 questions. The first question is that is the patient's vital stable? That's the first question. Vital signs. And the next thing you need to ask yourself is the pupil size. Pupil size. The pupil size. Pupils. The size of the pupils. Right? If the vital signs are stable, the patient doesn't have any symptoms, right? Or the patient is just having lower motor just having lower legs weakness and all that, I would want you to think of a subfall sign or cingulate herniation. cingulate herniation. If the vital signs are normal, so let me write N here, and you see a herniation syndrome, and the patient doesn't have any respiratory distress, does not have any bradycardia, does not have any features. The patient just has lower motor weakness, right? I want you to think of cingulate fascia. Why should you think of cingulate fascia? That's the question. Because why? The arteries affected in a subfascian herniation or a cingulate herniation is the anterior cerebellar artery. Right? That is why. If the vitals are not stable, the patient is unstable, having very cardiorespiratory depression and all that, I want you to think of a cerebellar or a tonsillar herniation. That's what I want you to think of, right? That's what I want you to think of. When you think about it, right, that's the first thing I want you to think of, because the respiratory center, the cardiorespiratory center is located in where? In the medulla and the pons. So basically, if you're having an herniation there, to affect that region. So that's the first thing I want. Now, when you now have pupil size, if the patient, they tell you in the question that the patient's pupils are dilated, right? Dilated. I want you to think of onchyl herniation. If they tell you that the pupil size are small or constricted, so there's kind of like meiosis, I want you to think of central transtentorial herniation. If the pupils are dilated, I want you to think of onchyl herniation. So basically, I'm trying to tell you of a way to kind of like get your easy points when you're like seeing questions in herniation, basically. So basically, what happens, let me go here to kind of explain what happens in herniation, basically. So for the cingulate and subfascian herniation, there's actually a compression of the anterior cerebral artery. That means the subfascian region herniates under the falsi cerebri. That's why it's called subfascian. So it's under the falsi cerebri, basically. That's why it's there. And it compresses the anterior cerebral artery, right? So it causes lower motor weakness. There are no sensory symptoms. There can be sensory symptoms though, but it doesn't affect the vital signs of the patient that much, right? Doesn't affect the vital signs of the patient that much. But when you have a central or transtentorial, it means that it goes downward, right? You are pushing against the pons. You are pushing down against the pons, right? That's what's happening basically. You are pushing down against the pons. So there's pressure on the pons, right? Or the midbrain. You are generally just pushing down on the midbrain. You are pressing it so hard. You understand? What that patient will now present with for the central transtentorial is that the patient will present with very bad things, right? The patient will present with weakness, overall weakness. The patient can present in coma. Because why? If you remember when I drew the circle of Willis, when I drew that circle of Willis earlier on, I mentioned that there's an artery that runs down, right? That runs down off the, that runs down straight, and then there are arteries that branches off here. These arteries are the ones that are affected in the central transtentorial herniation, CT herniation. Those are the ones that are affected in central transtentorial herniation. And these patients usually present with small, irregular pupils. Small, irregular pupils. Right? Small, irregular pupils, right? That's how these patients present with in the early phase. In the late phase, they tend to have irregular pupils. So they have irregular pupils, but it will still be small. So it is small, it is irregular. That's how you know a patient has central transtentorial herniation. The patient will have a small irregular pupils, and then the patient can have other symptoms, basically. The patient can have basic brainstem malformality. So there are a lot of tracts that will be affected there. The corticospinal, this one, that one. Basically, that's what the patient have. But the hallmark symptoms that I want you guys to remember for a patient that has central transtentorial herniation is this small irregular pupils, right? For the onchyl herniation, what the patient has, the patient will have. So basically, what's happening in the onchyl herniation is that, right? So this midbrain here, this is the midbrain, basically, right? There's a temporal lobe, an extension of the temporal lobe called the uncus over here. So when blood gathers around this region here, it pushes this lobe towards the midbrain, right? And when it pushes this part towards the midbrain, what does it do? It compresses the cranial nerve 3 over this region here, over the midbrain here. So when it compresses this, of course, you know, in the midbrain going down, you have the corticospinal tract that's going down. You have the corticospinal tract that's going down, right? So the corticospinal tract is going down. The cranial nerve 3 nucleus is located in this region. So basically, this uncus is compressing this tract and this nucleus here. So patients with uncal transtentorial herniation at first we present with what we call ipsilateral. So the cranial nerve, you know, I told you that cranial nerves, all cranial nerves tend to have ipsilateral involvement. So the patient will present with ipsilateral cranial nerve 3 palsy. So what does this patient present with? The patient will present with dilated pupils. So the patient will present with dilated pupils, ipsilateral dilated pupils. Ipsilateral dilated pupils. That's what the patient will present with, right? That's what the patient will present with when there's an uncal herniation, right? So it's compressing the midbrain, compressing the corticospinal tract, compressing the cranial nerve 3 nuclei. So the patient will present with ipsilateral cranial nerve palsy. But because the corticospinal tract carries contralateral fibers, the patient will now present with contralateral hemiparesis. So the patient will early on, so let me just write this, early on in the presentation. So for uncal herniation, so let me just write this here, right? Uncal herniation. So let me write UH. In the early part, for uncal herniation, in the early part, the patient will present with ipsilateral cranial nerve 3 palsy, right? And then the patient will present with contralateral hemiparesis or hemiplegia, right? But what now happens over time when the bleeding becomes so much, it pushes this uncal to compress against this midbrain, and then the midbrain bulges on the other side. So let me use this marker to show you what I'm talking about. So the midbrain bulges on this other side here. It bulges. It now starts compressing the uncus of this other lobe here. It starts compressing the uncus of this other lobe here. So what does that do? Or it compresses the temporal lobe of this side here, right? So late in the presentation, this presentation will be reversed, right? And you know that because it's compressing the uncus and the midbrain on the other side, the patient in the late presentation will now be having what we call Kernohan's phenomenon, where because there's a compression of the opposite temporal lobe and the other side of the midbrain, the patient will now present with a contralateral. So it's giving you a false sensation, a false description of where the lesion is. So the patient will now be presenting with contralateral cranial nerve 3 palsy, right? The patient will now be presenting with a contralateral. Let me clean this, sorry. Let me clean this. So the patient will now be presenting with a contralateral cranial nerve palsy. Cranial nerve 3 is now contralateral. It's now contralateral. Because here now you are compressing the contralateral part of the corticospinal tract of the midbrain, the patient will now present with ipsilateral hemiparesis. So ipsilateral hemiparesis. So there's a reverse of the trend. That reverse is what we call the Kernohan's phenomenon. So that's basically what happens, right, in the Kernohan's phenomenon. So initially when it starts, there's oncal herniation, compresses that part of the midbrain that carries the corticospinal tract, and then the cranial nerve 3 nuclei. So initially, the patient will have ipsilateral oculomotor nerve palsy, and then contralateral hemiparesis. But as the bleed becomes bigger, and then there's more compression and more compression and more compression, the midbrain now bulges on this side, compresses the temporal lobe here, and then the opposite tract is affected. So when the opposite tract is affected, the patient, there will not be a reverse of the symptoms. So you now have, instead of having ipsilateral cranial nerve 3 palsy, what you now have is the contralateral cranial nerve 3 palsy instead, and then you now have an ipsilateral corticospinal tract involvement, which will lead to ipsilateral hemiparesis. I don't know if this thing makes sense, guys. Does it make sense to you guys at all?
Yes.
Okay. Yeah, so that's basically what you need to know about herniation. So the last topic for the day, this is going to be the last topic for the day. Sorry, guys. I'm just going to introduce brain tumors, and we're going to stop here. I'm going to introduce brain tumors. We're going to stop here, right? So we have brain tumors, right? We have childhood and we have adulthood. Adults, we have children, right? Now, for the adult tumors, there's a mnemonics you can use to remember it, basically. The mnemonics is GM shop, general manager's shop. General manager's shop, right? This G stands for glioblastoma. 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 The M stands for meningioma. The N stands for meningioma. The S stands for schwannoma. Schwannoma. The H stands for hemangioblastoma. The O stands for oligodendroma. Oligodendroma. And then the P stands for the P, I'm trying to remember the P again.
The pituitary. It's the pituitary adenomas.
Adenoma, yes, the pituitary adenoma, yeah, pituitary adenoma. Thank you, Doc. Trying to remember the P. Pituitary adenoma, so PA. So pituitary adenoma, right? Pituitary adenoma. Okay. So this is where I'm going to end our class for today. I'm going to introduce these tumors, and then for the children, we'll talk about it as well when we do our next class. I'm going to talk about each and every one of these tumors, how you're able to recognize them on CT scan, MRI. I'm going to talk about all of that. So I think that's going to be the end of today's lecture. Do we have any questions? Yeah, questions. Okay.
So I've got a little question. Just when you started about talking about herniation, you told based on vital signs it could be differentiated. Could you please repeat that part again?
Okay. So I explained herniation syndrome. I listed the 4 types of herniation syndrome, and I said that when you see a question in herniation syndrome, basically, there are 2 things that you should ask yourself in the question. 2 things, right? 2 things you should ask yourself is HT, herniation syndrome, right? HS, or rather. The first thing you should ask yourself is vitals. What is the vitals, right? The next thing you should ask yourself is the pupil size. So when you see a question about herniation, and you're like, oh, this question is about herniation, these are the 2 things I want you to ask yourself. What happens to the vital signs, right? And then I said that if the vital signs are normal, Vital signs are normal. The patient only has weaknesses, lower limb weakness. That's all basically. The patient most likely has a cingulate or subfile sign herniation syndrome. If the vital signs are normal. If the vital signs are not normal, so there's bradycardia, there's hypotension, there's anything, any abnormalities in the vital signs, basically, right? What you should think about is a cerebellar or tonsillar herniation. So let's just write CT, right? That's what I talked about vital signs. When you see a question about herniation, you just draw these two things I just mentioned. Vital signs, pupil size. What happens to the vital signs? Is this patient having a normal vitals? If they're having a normal vitals, then okay, this patient most likely has a cingulate herniation. If this patient is not having a normal vitals, having abnormal vitals, with other associated symptoms, headache, seizures, some kind of things like that, you should be thinking of a cerebellar or tonsillar. In fact, most times, patients with cerebellar or tonsillar herniations, they usually die because, of course, there's compression of the medulla and the pons, basically, and those places are the seat of wakefulness and the cardiorespiratory centers, respectively, right? The pupil size, you look at it, you ask yourself, what is the size of the pupil? Is it small and irregular? If it's small and irregular, you're thinking of a central transtentorial herniation. So transtentorial herniation, CT. If the pupils are dilated, basically, they are dilated, they are blown out, they are dilated and bloated, they are out and down. That's the right word. You'll be thinking of an uncal herniation, uncal transtentorial herniation. So that was what I was trying to explain by that diagram. I don't know if that's clear. When you look at the question, that's what should come to your mind. Okay. So let me answer the questions we have here. Did you get it, or should I go over it again?
Yes, I got it. Thank you so much.
Can you
Okay.
repeat the pupil size?
Yeah, I said that the pupil size, if the pupil size is small and irregular, that means the pupil size, you check the patient, you do an examination, or they do an examination finding, and they tell you that this patient that has an herniation syndrome has a small pupil size. The pupils are very small. That means the patient has meiosis, very small, right? You'll be thinking of a central transtentorial herniation. But if the pupils are dilated, they are blown out, you'll be thinking of an uncal transtentorial herniation. That's what I'm trying to say. I don't know if that's clear. All right.
Yes, thank you, sir.
Yeah, so somebody said I should summarize tuberous sclerosis and Sturge-Weber. Okay, let me go over it again and try and make it. I'll try and summarize it so it will be fast. So Sturge-Weber, let me just say the highlights of what I said. Sturge-Weber, let me just say it quickly so that we can end the class, right? So Sturge-Weber, what happens in Sturge-Weber basically? So let me write this. Sturge-Weber, right? Eyes. What happens in Sturge-Weber? There's a mutation in this gene, a somatic mutation. Somatic mutation in this gene called GINAC or GINAC gene. GINAC1. So there's a somatic mutation in GINAC1 gene. This gene is responsible for differentiation of blood vessels into arteries, vein, capillaries in the brain and in the meninges, basically. So it's responsible for differentiation of blood vessels in the meninges and the brain, right? So what happens is that when there's a somatic mutation, they call it somatic monozeism, basically. But when we get to biochemistry, I'll deal with that. I'm not going to talk about that here, right? So when that happens, when the mutation hits this gene, the genes won't be able to help with proper differentiation of the blood vessels in the brain. So this leads to tangling of the blood vessels, abnormal formation of the blood vessels in both the arachnoid matter and in the brain. So these patients basically present with three symptoms, right? In the brain, they will have what we call leptomeningeal, they present what we call leptomeningeal angioma, right? They'll also present with intellectual disability, right? Those are the two things they'll present in their brain. For the skin, they usually present with a very unique feature. You can't miss this on the exam. If you see this on the exam and you miss it, then there's a problem. They present what we call port wine stain. Port wine stain. And this usually follows the trigeminal nerve trajectory. So it affects V1 of the trigeminal nerve and V2 of the trigeminal nerve. The other thing that this thing affects is the eyes. So what happens is that the blood vessels in the episclera are also affected. So these patients have what we call episclera hemangioma, hemangioblastoma, basically. And then these vessels in the episclera easily rupture. It's not properly formed, and so because it's not properly formed, these patients tend to have leaky vessels. Like the vessels tend to just rupture and bleed, and then these patients are at risk of having raised intraocular pressure, and they come down with glaucoma. So I was saying that in the question they usually tell you, oh, what associations can you have in patients with Sturge-Weber? And I said that one investigation you want to do for them is a tonometry. You want to do a tonometry for them, or fundoscopy, so check the pressure of the intraocular pressure for them in their eyes. So you check it, do a tonometry, because they are at risk of early onset glaucoma, because there are blood vessels that bleed easily, or malformed blood vessels that bleed in the episcleral space, and all of this compresses the eyeball, and then there's an increased intraocular pressure, right? That's what I said about Sturge-Weber. Now, I don't know if that's clear. Do I have to? Is that clear? I want to go to tuberous sclerosis so that I can round up, right? So for tuberous sclerosis, I gave some awesome mnemonics. For tuberous sclerosis. I said that tuberous sclerosis you should remember two things, right? You should remember, well, there are a lot of things you should remember, but the one thing you should remember is tuberous sclerosis, right, affects two organs that have tubes. These organs have tubes, the heart and the kidneys. So it has tubes, affect organs that have tubes, basically, right? And anytime you remember tuberous sclerosis, you remember TSA. That's the second thing you should remember. The first thing you should remember is that it affects two organs that have tubes, the heart and the kidneys. The second thing you need to remember is the TSA. This is a mnemonics that I created like by myself, right? The second thing you need to know is that it's affected by a tumor suppressor gene, TS1 and TS2. And usually in the exam, they usually try to test whether you understand which chromosome is affected and what is the name of the tumor suppressor gene that is affected, right? So what I said is that for this one here, you're going to add 2 to it. So 1 plus 2 is 3. And when you raise that to the power of 3, you have chromosome 9. Now, this tuberous sclerosis 2 has 2 here. So if you add 2 to it, you have 4. 4 raised to the power of 2 is 16. So TS1 gene is located on chromosome 9 and TS2 gene is located on chromosome 16, right? Now, this TSC1 is known as hematine, right? And this TS2 is known as tuberin. So how do I know which one is hematine and which one is tuberin? H comes before T. So 1 comes before 2. So I'm able to know that this is hematine and this is tuberin, right? That's the first thing. These are the 3 things I want you to know first. Do you understand this part? Are you okay at this point? Are you okay here? Okay, great. So now let me go on, right? Now, I now said that these patients present with symptoms that affect 3 organs, basically. Because it's a neurocutaneous disorder, it primarily affects the brain, it affects the skin, it affects the skin and others. These others involve these two organs here, the heart and the kidneys, and I'll come to this. But in the brain, these patients usually present with astrocytoma. They usually call it giant cell astrocytoma, right? Giant cell astrocytoma. And then in the skin, they usually present. Now, I'm using these mnemonics to try and figure out what they present with in the brain, the skin, and others, right? For the A, they present with astrocytoma in the brain. For the A, in the skin, they present with what we call ash leaf spot. They also present with what we call they present with what we call an angiofibroma. Angiofibroma. So they are like pimples on the face and nose, right? Angiofibroma. So they present with angiofibroma. These are like pimples, like acne-like lesions on the face, fibroma, right? And then the S here stands for Chagrin's patch. Chagrin. Chagrin's patch. Now, when you come to the secondary involvement, which is the others here, they usually have heart and kidney involvement. For the heart, they tend to have what we call cardiac rhabdomyoma. Cardiac rhabdomyoma, right? Rhabdomyoma, right? Then for the kidneys, they tend to have what we call renal angiolipoma. Angiolipoma, right? That's what they tend to present with. Right. I don't know if that's the summary of both of them. That's the summary of both of them, basically. Right? That's the summary of both of them, basically. I don't know if that makes sense, guys. Okay, so come to the end of today's class. If there are no other questions, that's the end of today's class. Thank you guys for being part of the class. We're going to go to tumors and then neuropharmacology, then ophthalmology and ENT, and then we're done with we can wrap up neuro, and then we'll go through the slide sessions too. Okay, so thank you guys for coming. Thank you guys for being part of the class.
Thank you.
Yeah, thank you guys, Mokodi, Victoria, Saba, all of you. Thank you guys for the compliments, Sunshine, Guni, all of you guys. Thank you guys so much. Dr. Jude, thank you guys. Shamila, thank you guys. So I have to allow you guys to go. Sultana, Zelva, thank you guys. Miriam, thank you guys. So we'll see you in the next class, hopefully. So take care, guys.
Thank you. Thank you.
Yeah, Dr. Jamil, thank you to Dr. Aska, thank you too. Okay, so take care, guys. Thank you, Dr. Victoria.